All right, thanks, Jeremy. Just to start off with, does anyone recognize who this man is? I guess with a normal audience, we'd be able to get some response, but
they're all muted, unfortunately.
I was looking in the chat, but this is Magic Johnson. I'm not sure if that rings any bells, but definitely someone who was a huge part of my childhood for a number of reasons. Number one, he was one of the most decorated NBA basketball players in the US. He played for the LA Lakers and was almost always in the winning team, and was also part of the dream team that won a host of Olympic golds. But what was, for me, as I sort of grew older, what was most fascinating to me was that he declared his HIV status in 1991. He was 32 years old. And at the sort of almost at the peak, basically at the peak of his career, he declared his HIV status. It was obviously an enormous revelation at the time. It's the early 90s. Drugs were only to happen in the distant future, and he actually retired because of it. And so little was known about the infection at the time. And so as he stayed out of the game, he became a major advocate for HIV at a time when it was an enormous taboo. And so he's now 62 years old. This is a recent picture I found of him, and you can see that he's fighting fit. He's progressed from playing basketball to running a number of huge companies. He's a major HIV advocate, and at the ripe old age of 62, after having lived with HIV for more than 30 years, certainly one of the inspirations that I think of when patients discuss getting old with HIV with me in my consultation. So why do we need a whole separate talk on aging with HIV? I mean, after all, isn't it now so desperately easy to treat? We just put patients on ARVs, monitor their bloods a couple of times a year, and continue until one of us retires or moves away. This obviously is a reference to the recent trial, came out about 3 weeks ago in the NEJM, the Nadia trial, which looked at either dolutegravir or darunavir in combination with either an AZT plus 3TC or tenofovir plus 3TC. And it answered a lot of questions we had about chopping and changing the regimens. We won't go into the details now, but the discussion on our RD specialists' WhatsApp feed involved one of the RD consultants from Bloom saying, basically, it means we've lost our jobs as experts because we don't need to give advice on complicated regimens anymore. So has it really become that easy, and we don't really need to stress too much about the patients? But to paraphrase the pediatricians, elderly patients are not just big adults. When we think about HIV medicine and geriatrics, there's actually an enormous overlap. This Venn diagram is the result of a multitude of discussions that I've had with my wife, India Butler, who's a geriatrician. That's my only one major disclaimer. And when we discuss our different fields, there are a lot of similarities that are noted. Firstly, they're new disciplines. Initially weren't taken terribly seriously, but now as things have progressed, people realize that they are disciplines in and of themselves. They're cognitive disciplines, so it involves a lot of problem solving within the patient's clinical presentations and the pharmacology involved. They're very complex. There are a lot of dynamic issues at play, medical, social issues. They are marginalized patients. I think one of the reasons some of us are attracted to HIV medicine is that a lot of the patients are marginalized from a number of sort of social entities, and it's similar with geriatrics. And the thing that's really only dawned on me over the last few years since being in practice is that it's a continuum of care, and I think it's one thing I didn't really realize when doing my training, because we would see different patients in the clinic on different days, but now being in a practice, we see the spectrum of care from over the course of a few years, and it's much the same with geriatrics. The other thing that I must say that there's a lot of overlap with is that we are both obsessed with de-escalation. So we love de-escalating antibiotics, and the geriatricians love de-escalating, or what they call de-prescribing neuroleptics and psychotropic medications. The other thing that differentiates older patients is the gradual deterioration in the immune system, and it's based on 3 pillars: the humoral immunity, cell-mediated immunity, and the compromised physical barriers. So with humoral immunity, there's reduced immunoglobulin levels, there's impaired activation of B cells, and so older patients have a unique susceptibility to encapsulated organisms and also an impaired response to vaccines. There's compromised cell-mediated immunity, where there's reduced absolute number of CD8 T cells, and the host response is affected in a number of infectious situations. And older patients also have compromised physical barriers. So they're very frail, their respiratory cilia is compromised, they've got poor cough reflex and poor swallowing, and they're often subjected to a multitude of different devices like catheters and pacemakers and things. So with patients with HIV who age, there's also the persistent inflammation that patients with HIV have. Even with ARVs on board, there's ongoing inflammation and immune activation. And we see some of the complications that develop over time. On the left-hand side by the blue oval, the metabolic syndrome aspects, and on the right, the orange oval are the cardiovascular disease components. And these happen over the course of time. They happen in spite of or despite being on ARVs, and it really is a function of the passage of time and the chronic inflammation that patients who are well controlled on ARVs what they're subjected to. The other thing with older patients is that they have a greater degree of comorbidities. This is taken from a UK public health database that documented a whole number of parameters, but they looked, obviously, as you see on this table, at a number of different comorbidities and how with increasing age, there's a steady increase at midlife, and then once we hit 60, 65 and up, there's this rapid increase in comorbidities that happens in older age. Now, in South Africa, we have a significant number of patients who have a high HIV prevalence in older ages. So in the world of HIV, older patients are considered 50 and up. And we see that over time, there's over the between in a 5-year period from 2012 to 2017, there has been an increase in the prevalence in the HIV in older adults, which is certainly something that we experience in the clinical setting. This diagram just shows the rate of progression to AIDS or death by age. This is patients who have started ARVs within 5 years with high viral loads, no prior AIDS-defining illness. And we see that at equivalent CD4 counts, the rate of progression to AIDS or death in higher age groups is higher compared to younger age groups. Another aspect of older patients is that they often present late. And this is either something from their side or something from our side. There's obviously a lack of awareness regarding HIV in these age groups. We don't often appreciate that, people may have had HIV for a number of years and only present later on in their 50s and 60s, and we don't often appreciate that people in older age groups also have sex and are also exposed to HIV transmission in those age groups. And there's also a really low index of suspicion, and I know I'm certainly guilty of this. Also, there are conditions associated with HIV that are more common in all aging adults. So things like herpes zoster is something that could happen in all age groups or as one gets older, and things like pneumonia as well. And the graphs on the right hand side just show the increase in those with AIDS-defining illnesses at the time of presentation in older age groups. But this was taken from a big veteran affairs cohort. Looked at a few thousand patients, and we see that in older age groups with the equivalent CD4 counts, there are a higher number of late presentations and presenting with AIDS. So this is taken from a study that India did for her MED. It was based on the huge and amazing database from Tembuletu at Helen Joseph Hospital, and she looked at a number of factors in older adults who were in HIV care, and this slide just summarizes some of them. So the prevalence of HIV in older adults is predicted to double in the next 30 years. We mentioned that the diagnosis is often missed or delayed. They progress faster to age, and there's a higher mortality. They've got a double burden of immune deficiency, the HIV plus the immune senescence that happens with older age. But interestingly, there's better or similar virological response and better adherence. It turns out that older adults are a lot more motivated to drink the medication and a lot more compliant overall than those in younger age groups. The CD4 response is unfortunately delayed, so the immune deficiency continues for a prolonged period of time, and there are a lot of drug interactions and toxicities and comorbidities that they found, and we're going to discuss a couple of them. So in preparation for this talk, I found an article that deals with an assessment of older patients with HIV, and it gives what I found a very simple, very easy to remember framework to work from. And I think this is something that we, working in HIV, we experience this in our consultations anyway, and we consider a lot of these factors when we go through our consultations with our patients. But it was great to see it so clearly sort of tabulated, and we're going to go through each of these M's. In older age groups, the mind component is obviously a huge factor to consider. But we must always remember to evaluate and treat mood disorders and the polypharmacy issues that come with treating these patients. There is a great deal of cognitive decline that happens in these patients as we start adding on more drugs to their script. There's a much higher prevalence of depression in people with HIV. It's 20 to 40% versus about 7% in the general population. It causes increased disability, and the treatment outcomes are poorer in those patients who have got depression. And a simple screen is a simple screening questionnaire. I think it's 4 questions that needn't be done at every consultation, but certainly worth being done, because the outcomes are better if the depression is diagnosed and treated. When it comes to drug-drug interactions, this is something which, we may not all have the luxury of a variety of antidepressants, and I know that tricyclics at TCA are still a big favorite. But just if we look at the drug-drug interactions between ARVs and some of the antidepressants, we see that with the NRTIs and the INSTIs and all classes of antidepressants, there's no major drug-drug interactions. With the NNRTIs, there's a slight decrease in the levels of antidepressants across all classes. Whether it's clinically significant or not, that obviously depends on the assessment of the patient. And with the protease inhibitors, there's an increase in the levels of antidepressants across all classes. And I think over the last couple of years, a lot of us have been trying to move away from efavirenz and PIs to the integrase inhibitors. And so hopefully a number of these drug interactions won't be major factors in the future. With neurocognitive decline, there's obviously greater risk of cognitive impairment of patients with advanced HIV. And what's interesting is that even with ARVs having reduced the amounts of advanced HIV in the treated population, the prevalence of HIV-associated neurocognitive deficit, HIV-associated dementia, and mild neurocognitive disorder have been little change in the prevalence of that. Certainly, the most severe form that we encounter in our setting is still incredibly prevalent. The graph on the left-hand side was taken from a study done in Cape Town that looked at what happens to the cognitive response after these patients have been started on ARVs. And granted, it was a small study, but it does show that with patients who have HIV-associated dementia at the time of presentation on treatment, there's a good chance that their cognitive function will either stabilize or hopefully improve. Now, this is obviously one area where in HIV medicine versus geriatrics, things are a little different, because the dementia in geriatrics is considered a progressive decline, as opposed to the dementia in the HIV context, where with good ARVs and good control of HIV, there's a chance that the neurocognitive decline can either be stabilized or reversed. One aspect of the review or the clinical review in these patients that the geriatricians love is to draw a clock, and India keeps on telling me to get my patients to draw clocks. And so this is a clock taken from an NEJM case report from 2012, of a 39-year-old man who presented with advanced HIV, severe neurocognitive decline. He also had TB meningitis, but there you see an example of the clock that patients with dementia would draw. Clocks, as simple as they may seem to us, or should seem simple to us, they involve a great degree of planning, executive function, abstract thinking, and so that was just a nice illustration from the NEJ. Mobility assessments form a huge part of a geriatric consultation. Our setting, we don't really have that luxury because of the time involved. There are a lot of different scores and measurements that one can do. I think something that we are all familiar with, maybe not in the strict sense of doing a Frail scale, as is explicitly shown in this little table, but it's certainly something that we do during the course of our consultations, and we use it as a marker of prognosis, and it also enables us to liaise with the family and try and get a sense of what social assistance a patient may need if they are particularly frail. Medications, obviously in this age group, there are an enormous number of medications that these patients are exposed to. Some are active ingredients, some are inactive vitamins and supplements. And the Geriatric Society has actually come up with a whole list of medications that are commonly prescribed in older adults that have a lot of drug-drug interactions and are considered they're considered, they're ill-advised, let's rather say. It's not a prescriptive list, but it just says, if you're going to be using tricyclics in older adults, beware of the autonomic dysfunction and the potential for delirium, things like that. Now, polypharmacy is something that we are very comfortable with in the field of HIV. We have a lot of patients who are on a lot of drugs. Obviously, we try desperately to try and reduce that over the course of time. But certainly when we're seeing patients with advanced HIV, they're on all sorts of combinations and all different drugs doing really important things. And what's interesting is that, so polypharmacy is defined as anything more than or equal to 5 medications. There's obviously the drug-drug interactions that come with it, poor adherence, and interestingly, in the older age group, the mortality risk goes up significantly in anyone who's on 5 or more medications. And I think it's something, unfortunately, that we're very familiar with, is a prescribing cascade, particularly when we deal with something, let's say, like the peripheral neuropathy that we have to deal with, or some of the side effects of other medications. We get into this runaway cycle, this prescribing cascade, and soon we're prescribing something to treat the side effect of something else, and before we know it, the script of the poor patient is filling the page. This is from this Veteran Affairs cohort that we saw in one of the previous slides, and it just shows the number of concurrent medications that patients are on, and really just an unbelievable number of patients on all sorts of different things. I mean, 25% on non-steroidals. Okay, granted, maybe these are patients with arthritis and they need analgesic control, but really an incredible prevalence of concurrent drugs that these patients are taking. And unfortunately, as we well know from antibiotics and antibiotic stewardship, one of the aspects of managing older adults is sort of polypharmacy stewardship. That is not a real term, it's just something I made up just in reference to our experience, but with older adults, there's a great attention placed on trying to negotiate which drugs are important, which drugs aren't. We see that in older age groups, more than 80% are on more than or equal to 5 non-HIV drugs, and a significant portion of them are inappropriate. I must just quickly put a plug in for the University of Liverpool Drug Interaction app, the iChart, which really should be part of all of our daily practice. But I found this slide really interesting because it ties in quite nicely with the antibiotic stewardship that we try and practice day to day. Something that we're also familiar with in younger HIV patients, but in older HIV patients even more so, is the concept of multi-complexity or sort of comorbidities, where we have a whole host of comorbidities, lots of complicated drug regimens that we need to negotiate our way around, and sometimes we need to prioritize, and if something that we find is very beneficial but is causing the patient a lot of distress, or they're not tolerating the medication, then sometimes we have to prioritize which are the main drugs that we are going to be prescribing for our patients. So some of the comorbidities in older patients that we have to consider, probably one of the more important ones is ischemic heart disease. So as these patients survive longer, there's obviously an increased prevalence of metabolic disorders. HIV itself is associated with higher MI risk, and in those who are having their initial visit in older age groups, we should do an initial risk factor assessment, and in the older age groups, do a Framingham score, which really takes less than 10 seconds on one of the scoring apps or one of the calculator apps, just to give us the CVS disease risk. So with approaching minimizing cardiovascular disease, obviously the priority for us is always to suppress the viral load. ARVs that are associated with higher cardiovascular risk are the older PIs. One that's we still obviously use is the lopinavir, ritonavir, and abacavir. And then when considering CVS disease in HIV patients, the risk reduction and the advice and the strategies that we employ are identical to HIV negative patients. I think the one big question in this group regards aspirin as a form of primary prevention. I think there's a big trial happening at the moment on using aspirin in various doses as primary prevention, but at the moment it seems like there's still no role for it. The one big comorbidity that we often deal with are the dyslipidemias. So higher LDL increases cardiovascular risk, and reducing it lowers the risk. Higher HDL probably reduces cardiovascular risk. And when it comes to the triglycerides, this is a little murky in terms of the independent risk associated with high triglycerides as a cause of cardiovascular disease. And it's not sure whether there's a cardiovascular benefit in treating patients for their high triglycerides. So when we do encounter these patients with high lipids, obviously we advise them on diet. I would think a lot of us have dietitians available, if not in the clinic, then certainly a dietary or dietitian or dietitian service within the hospital that can advise patients on this, although I do understand it's obviously a very, very difficult thing to advise from a dietary point of view for a lot of our patients. If not, then we can consider changing ARVs. We'll talk about that in a moment, and then consider lipid-lowering therapy. Statins are often strongly recommended for those with established cardiovascular disease, type 2 diabetes, and those who are at high risk of cardiovascular disease. And that risk, it can be calculated based on the Framingham score. So when we come across patients with high lipids, we should look out for secondary causes, so diabetes, thyroid disease, liver and kidney disease, and alcohol use. When it comes to the different classes, the NRTIs have a variety of lipid effects across the class. In the NNRTIs, efavirenz increases total cholesterol and triglycerides. It increases the cholesterol to a higher degree than atazanavir ritonavir. And rilpivirine seems to have less of a dyslipidemic effect when compared with efavirenz. PIs as a class, and particularly relating to ritonavir, increases the lipid profile. But atazanavir and darunavir combinations with ritonavir have a better lipid profile than lopinavir ritonavir. And the integrase inhibitors have a little effect on lipids. So just some switch strategies if we do encounter patients who are on ARVs and have dyslipidemias. The NRTI switch that we can use is from a back of a 3TC to FTC TTF. NNRTI, if we're going to be using an NNRTI, then rilpivirine would be the one of choice. And there seems to be a good metabolic profile with using the integrase inhibitors, and certainly the dolutegravir 3TC combination is a good option in these patients. Now, back in the day when we only had a couple of statins at our disposal. Simvastatin was the dreaded statin that was contraindicated with patients who are on ARVs. But we now, I think for the most part, a lot of us who have access to atorvastatin would have that as our drug of choice. And just I generally have to look this up most times, but just a reminder from the SA guidelines, this is from the dyslipidemia consensus statement, just regarding the targets, the LDL targets. I think most of our patients would either be low or moderate risk. We should aim for an LDL less than 3. And for those who are high risk, we aim for either less than 2.5 of the LDL. Granted, I'm a little bit biased. I live with a geriatrician, so I have to hear about old broken bones. And I think with our experience within HIV, we're certainly starting to get a taste of this, as well as patients have been on ARVs and are aging. Certainly in the hospital I work in, we're seeing a lot of patients coming in with neck or femur fractures following falls, and they're on ARVs. So it's been interesting to consider some of the issues involved. So ARV initiations associated with a few percent decrease in bone mineral density over the first few years, and this is similar to the bone density decrease within the first couple of years of menopause. And there have been a few big studies looking at the increased fracture rates relating to HIV. There was a meta-analysis looking at fracture incidence between people living with HIV. That was just over 11 per 1,000 person years versus in the general population 1.5. And the thing that I found quite interesting was that in younger men as well, the risk is significantly higher, and obviously the causes of low bone mineral density in HIV positive patients is multifactorial. There are a lot of issues obviously relating to HIV, ARV effects, and the established osteoporosis risk factors. When we consider these patients with osteoporosis, we should always remember some of the secondary causes. See the table on the right. And when just taking a dietary history, we should get an idea of what their calcium intake is, what their vitamin D intake is, and what their level of physical activity is. Generally, when it comes to bisphosphonates, it's not something that I've necessarily prescribed a great deal of myself, but I think it's something that as HIV clinicians, it's something we might have to get our heads around. I often find that when I speak to patients who have been with me for a few years and we discuss being referred to another specialist, a lot of people are quite reluctant to have to go see another specialist and have to go through their whole story again. So even though things like writing up bisphosphonates are not really something we do in our day-to-day practice, is considering the number of patients that we are potentially going to be dealing with. It's something that we might have to become familiar with. From speaking to a few endocrinologists about dealing with these patients in the rooms, the guidelines in South Africa they recommend screening for bone mineral densities in women over the age of 65 and men over 70 with a DEXA scan. And getting a DEXA scan is not exactly an easy investigation to get. So it's not really practical in our situation to get a DEXA scan on these patients. And so probably the easiest strategy is just to give vitamin D to these patients in any formulation, and replace calcium using a Profferol strategy, which instead of getting special calcium tablets, just advise patients to drink a glass of milk a day. Then something that's I found quite interesting on the list of things to consider in a consultation or in an approach to these patients is getting an idea of what matters most to these patients. Look at what their priorities are in terms of the management. So, for example, the one thing that comes to mind for me in our situation with HIV are a lot of the side effects that people get with either TB drugs or INH prophylaxis or Bactrim, and I think we're quite familiar with working through the negotiation of, what impact do our interventions have on the quality of life of the patients. And certainly this is a major a pillar of caring for older adults, is that sometimes they don't want a statin if it causes their muscles to ache, and all they want to do is to be able to walk around the neighborhood or play with their grandchildren. And if there is something from our side that's going to inhibit that or obstruct that, then they would actually rather not have that intervention. And I think it's certainly a juggling act that we are very familiar with. Another thing that should form part of the initial approach is what are the modifiable risk factors and the lifestyle factors that we can advise on the patients. Obviously, we deal with very short consultations. There's a lot to pack into them. So these are obviously not things that we need to do on day one, but rather something that can be in the background throughout the course of subsequent consultations. It needed to be a part of a whole lifestyle audit for the patient on day one, but definitely something that I think when we're busy in a very busy HIV clinic, where our priority is to get the viral load undetectable and keep it undetectable, and sometimes some of these very basic things don't become a great priority. So what about initiating ARVs in these patients? So this is a slide that I took from a talk on the clinical care options website that looked at a nice summarized table of different trials looking at different regimens, looking at the virological suppression rates in the two age groups, less than 50 and older than 50. And we see that for the most part, the regimens that we use, the dolutegravir-based regimens, dolutegravir, either FTC or 3TC and TDF, there's no differences between the two age groups, and it's a difference or a lack of difference that extends to up to the 3-year mark. The thing that I'm starting to get more interested in is a 2-drug regimen, and definitely something that we will probably be moving hopefully towards sooner rather than later. And the last thing, just to briefly mention, is the area of vaccines. Obviously, it's very hot right now, but we're not talking about that vaccine or those vaccines. We'll talk about a couple of others. When primary care providers take 10 topics for discussion during Medicare visits, they prioritize them according to, well, they rank them in these 3 tiers that we see here. And obviously, the current presentation, the current clinical presentation is the main topic to discuss, issues related to general health and medications that the patient is taking. And we see quite low down on the list of vaccines. Now, I think this is something that we all experience, particularly around flu season, where we're very busy dealing with all the upper respiratory tract infections and the complications that happen during that time, and discussions about vaccines are not always top of the list. And I found this very interesting. I think it's also one of the things that when we think about the care of these patients, it's not something that comes up every consultation, but something that should be a topic to consider at a particular time of the year. So obviously, when we're seeing patients in October, we're not going to have a big vaccine discussion, but when it comes to March, April, when flu season is on the way, then I generally try and incorporate some discussion about vaccines into those consultations. This is taken from the vaccination guideline in HIV, adolescents and adults. And we see the recommended vaccines being the flu and the conjugated pneumococcal vaccine, hepatitis B, and then in certain situations, the polysaccharide pneumococcal vaccine. But I must say, I find the uptake within patients to be desperately low. And my approach is to try and come up with a batting order, and obviously not to bombard patients with talk of vaccines and a whole shopping list of vaccines from the get-go, but sort of pace it out and stretch it out. So when it's an appropriate time of the year, obviously a discussion about influenza vaccines, and then at another time we can discuss other vaccines. And obviously there will always be some patients who are major vaccine protagonists and just want to be jabbed in stereo from all sides at any given time. But I think a lot of our patients, the older patients, are a lot more circumspect about these things. And I aim for at least a flu vaccine, a hepatitis B vaccine for partners of the patients that we see. And then, the pneumococcal vaccine, the conjugated vaccine is still a little bit pricey. The polysaccharide vaccine is a bit more affordable. So depending on what patients can manage, I advise them based on that. So thanks very much. This was a list of really useful resources for people who are managing older patients with HIV. Finding information on a lot of the comorbidities in the context of managing HIV is quite tricky, but the European AIDS Clinicians Society guidelines has an excellent section on each of the different comorbidities, and for excellent talks and discussions, clinical care options website and the In Practice website, and obviously the apps that we use daily, helping us navigate through very, very complex drug-drug interactions. Thanks very much.
Cool, thanks so much. And thanks, really nice approach with the nice acronym to remember, or at least all the M's. Lots of questions. Some have been sent in the Q&A, some are in the chat, some are on WhatsApp. One I think is about this, I think the perpetual problem in HIV, especially with comorbidities, is that third drug. We've got dolutegravir, which is pretty benign, and lamivudine is pretty benign. So yeah, I think I agree with you. I think you've definitely, especially in the elderly, could consider the Gemini results in the appropriate patients, with a decent CD4 and not a terrible viral load. And then some of the questions that have come up about that, was asking for about TAF instead of TDF. We don't yet have TAF in the country, I don't think. But when it does come, or at least when it's registered, where would you place that, especially for the elderly, Evan?
Yeah, I think there certainly seems to be a better, obviously we know about a better renal profile, but also a better bone profile with TAF. I think it would certainly, for a variety of reasons, be better placed than tenofovir, hopefully in future regimens. But yeah, I must say, just from seeing some of the data on 2 drug regimens, we might not even need a third drug, hopefully. Yeah,
that would certainly be ideal. Nasisa asks about the cardiovascular risk with abacavir, because obviously it's eternally controversial a question. She was saying she thought it was okay in the end. Where do you sit on that, Evan, in terms of abacavir, especially with the elderly?
I don't really know too much about the actual numbers of it, but certainly if it's possible to avoid in those who have got established ischemic heart disease, I do try and avoid it. But very often with these patients, our backs are against the wall, and we have to juggle, either giving tenofovir with potential nephrotoxicity or a patient with renal dysfunction, versus giving abacavir in a patient that might have some other risk factors for atherosclerosis. And so unfortunately, this question plays exactly into the hands of these difficult negotiations that we have to work out. My feeling overall, though, is that I think with tenofovir and renal dysfunction, that the evidence for that seems to trump abacavir and atherosclerotic risk. So it doesn't form a major part of excluding it from a regimen if there are other issues related to renal dysfunction.
Yeah, agreed. And as you said, they often have both, inevitably. As soon as they have a back of a respect, they usually got renal failure too. Then Narcisa making the comment about the pediatricians being worried about TDF and pre-pubertal children because of the potential impact on bone mineral disorders later on, and saying that the physicians must inform us of this future potential effect. I mean, it's a really good point. I mean, I don't know in terms of longitudinal studies. I mean, they must be out there, but I'm actually not sure what the latest is in terms of if it's used on the younger children. Obviously, I think it's, as Lucy says, it's currently indicated from 10 years and 30 kilograms. So obviously not using it before that point, but afterwards, what the sort of long-term effects are. If anyone else does, just to shout or raise your hand or type in the chat. But it is a good point. It's something. So the old for the pediatricians is still young for us, but they may have some of the same side effects. And then Ibrahim saying that he's also mentioning a really good point about another dual regimen of rilpivirine plus dolutegravir Juluca for elderly suppressed patients, because there's obviously some nice evidence there, and relatively few drug-drug interactions, and the bone and renal is also spared. So that's, I suppose, another good 2-drug regimen. I don't know. Have you had much experience with that, Evan, in terms of the elderly patients?
Just I think two patients. One I had with Claudia de Vale, a patient who had significant renal dysfunction and osteoporosis and a whole host of comorbidities. So it's I haven't used it a lot. I'm sure maybe others have used it, but I've found it a very, very useful regimen when there's so many comorbidities being juggled in the air at the same time, and there's good data on sustained virological suppression with that regimen.
Yeah, it's again probably an underutilized regimen for us as well, and as you said, avoids a lot of the side effects. It's always a little bit tricky with rilpivirine in terms of food interactions and drug-drug interactions occasionally, but it may well be a better option than many of them. And as you said, it's got good data for it. So that's excellent. Awesome. Thank you.
Try find a patient that's not on a PPI as well.
Yes, that's true. Although I suppose you could separate it if you really, but yes, it's as you say, you start clocking up the side effects to each of these drugs. Yeah, thank you so much. That's really awesome. Thanks. And thanks for such a nice approach for a complicated topic. I suppose with time, we'll probably all be attending CMEs with, approaches to all these lifestyle diseases, which we've forgotten about when dealing with HIV patients. Cool. Thank you.